Hello, I'm Dr. Donald Jurivich. I'm a professor of geriatrics at the University of North Dakota. This presentation is brought to you by HRSA and the Geriatric Workforce Enhancement Program. The location of this presentation and other resources for geriatric education are located at the website noted below. This presentation is on What Matters, Part 3. The goals here are to look at a more, if you will, 30,000-foot view of what matters within the context of the 4 M's, both their assessment and management plans. We want to look at quality improvement as a way to strengthen the 4M of what matters. And we want to also consider how to strengthen patient-centered care by addressing cultural aspects of what matters. So here's a case study. You're part of a team, and the quality improvement director indicates that there's a goal of documenting what matters by 90% or better in all patients. Your team B, okay, so you can see you're here in the orange, and right now your team, like everybody else's team, has less than 50% documentation of the advanced care plans. So the next best step to improve the quality metrics on this factor of what matters would be, well, what would you do? Put a sticky note on your workstation to remind you. Create a personal what matters phrase in your electronic medical record. C, would you want to join colleagues in a plan, do, study, act cycle of change to improve the documentation of what matters? Or would you instruct one of the staff to ask the patient what matters? So if you answered C, the plan, do, study, act cycle of change, that would be the correct answer, because basically we want to understand our system or your system of healthcare and to apply the right remedies for improving the documentation of what matters. So that comes through the plan, do, study, act cycles. And so you plan a change that you want to test. You then, in a small way, just with a handful of residents or patients, you test it. You look at how well you've done with that new test, and then you decide whether you want to move forward with that intervention or design another one. So you can look at health systems change and these ability to pursue quality improvement through the Institute for Healthcare Improvement here cited. And this is a toolkit for ways to design better ways to understand what older adults want in their healthcare. So one of the suggestions is to have a pre-visit patient preparation moment. And so you can send out a pre-visit questionnaire on what matters. You can do this through the electronic medical record or by snail mail. You can even do a pre-visit phone call if you wish, and we'll look at what that might look like. You can have a card deck either on site if it's long-term care or in the clinic that has a list of different things that are healthcare goals. And you can ask the older adult to organize those into the highest priority to the least priority. We talked previously about target practice, where you, again, use cards or stickies to align them with the number 1, number 2, number 3. There's a thing called the patient passport. I have a reference down here for where you can find that. It's basically written documentation of what matters that's brought as a passport to each clinical visit. So hopefully some of this information would be documented in the electronic medical record or in the written medical record if that still exists. However, this is something that in lieu of that you can have this passport, and it shares all the different features of what the older adult wants healthcare workers to know about them. So you can see this healthcare provider here looking at multiple pictures on a Zoom meeting. And this is basically what we call a moderated visit, where older adults collectively discuss their goals, their preferences, and some of their shared experiences to define what matters most to them. Another way to interact is through community healthcare workers. And so by contacting these individuals, you can help them guide the process of advanced care planning with older adults. There are electronic medical record templates that look at the self-perception of health, so-called the SF-36 form. There are templates for asking about health concerns, what the older adults' health values are, what their goals are, and what their care preferences are. And again, all these can be filled out prior to the clinic visit or guided through, for example, an annual wellness exam. So it's important to get training, both in terms of health professionals as well as administration to approach the question of what matters through motivational interviewing, open-ended questions, understanding shared decision-making so that you're just not dictating you must do this. It's rather what can we do to make things better. There's a reference here to Jurivich, which is a model for communicating, and again, it's a reference for that you can consider and look up. I also want to talk about cultural diversity and what matters. Firstly, it's important to identify what the older adult and how they want to be addressed. You also should indicate language preference, so having an interpreter might be useful. And also be mindful of nonverbal communication. So particularly people that are cognitively impaired, you don't want wrinkled eyebrows. You want to keep your eyebrows elevated, which is more disarming and more comforting to the cognitively impaired older adult. Also use pauses frequently. This helps the older adult digest, particularly if they're hearing impaired. There may be cultural preferences for pauses, again, to digest the material, to think so that they can ask questions. So again, the cadence needs to be a little bit slower, and the communication, generally with the older adults, should be a lower tone and a little bit slower pace, again, for accommodating some of the neurosensory deficits that come along with aging, particularly hearing loss. Very important in new Americans and refugees to assess post-traumatic stress syndrome. They, some studies show that 60 to 75% of new Americans experience some sort of traumatic stress. You also want to inquire about the patient's use of alternative therapies, plant medicinals, and a variety of other things that might be used that could interact with a medication regimen. And then lastly, and equally importantly, is to understand the role of the family in medical decision-making. Sometimes older adults will defer to their oldest son, or if in lieu of that person, the oldest daughter, or collectively for the whole family. So there's different preferences that the older adults will describe. So I just want to emphasize that by asking what matters, and its documentation has just huge impact on healthcare costs and savings. So by asking what matters, particularly in the hospital setting, you can decrease hospital utilization. Certainly that might be true in long-term care also. By asking what matters and identifying remaining life expectancy, that conversation can lead to an increased use of palliative care and increased use of hospice care. By asking what matters, it vastly improves patient satisfaction, which is a good thing. And then, most importantly, it gives back significant time to the older adult. So I'd like to summarize by saying that what matters is an ongoing conversation. It needs to be applied at each visit, and it can be bolstered or augmented by information gathered around annual visits. If there's changes in life events or a change in health status, that would be also an important moment to ask what matters, and if it's changed in terms of the advanced care plan, resuscitation preferences, and just overall healthcare goals. This needs to be coordinated among all team members, and so the idea of documentation of what matters needs to be readily accessible somewhere in the medical chart. And so it's important to have this available and where all people know how to access it. And then finally, I just want to point out that when you're gathering information about what matters to the older adult, it's important to keep in mind the cognitive status of the patient. Are they memory impaired or not? What is their health status? Are they at the final stages of their chronic illness? And then importantly, how does that impact their expected lifespan? And then the final comment that I want to make is that all of us need to be part of quality improvement. And so learning about the Plan, Do, Study, Act cycles of change, being able to get involved in quality improvement is a role for everybody. And particularly, it allows us to incorporate what matters into the everyday care of the older adult. So thank you for your attention, and I look forward to our ongoing conversation about the geriatric 4Ms and age-friendly healthcare.